My name is Kearsley Stewart, and I'm faculty here at Duke University in the Global Health Institute. And I also have a joint appointment in the Department of Cultural Anthropology. And along with my colleague, Gavin Yamey, who's up here on the left, I'm one of the faculty advisors for this conference. So it is indeed my pleasure and my honor to welcome you to our event this afternoon. Our speakers are here in the front. Welcome. We're really excited for you to be here. And we also have two speakers online via live stream, so welcome Sanjoy and Maleki. We should be able to see them when they're going to speak. So first, a few comments about our conference today. Today's event is part of the WHO Global Health Histories project. And this is a remarkable 15-year project which has been spearheaded and directed by Sanjoy Bhattacharya, who is a professor of history at the University of York in the UK. The WHO Global Health Histories project asserts that a critical and reflective understanding of the history of global health, especially over the past 60 years, is absolutely central to the future of global health. So we are delighted that today's event on decolonizing global health is going to be archived as seminars 140 and 141 on the WHO website. And Professor Bhattacharya will speak on panel 2 later this afternoon. Just a reminder, we're live streaming everything and recording it, and we'll be archiving it on the WHO website. So before I hand over to the Duke Decolonizing Global Health Student Group that laid the foundation for today's discussion here at Duke and also organized the conference, I'd like to take about 7 minutes and offer some thoughts about our topic, that is decolonizing global health, from the perspective of a cisgender white anthropologist, and to remark on two things: the calling on and the calling out of anthropology in global health. So in 2013, Richard Horton, the editor of The Lancet, reported on a meeting at the London School of Hygiene and Tropical Medicine that posed the question: is global health neo-colonialist? Horton concluded his opinion piece with the words of Derek Summerfield, who is a white South African who grew up in Bulawayo, Zimbabwe, and is now in the faculty of the King's College and a leading figure in global mental health. Yes, Derek Summerfield said, global health is neo-colonialist, he argued, and furthermore, he said that mental health workers are the new missionaries, propagating Western-imposed diagnoses that ignore local idioms of disease. How to counter neo-colonialist thinking in global health, he asked. Summerfield suggested the only way forward is to begin anthropologically, that is, with no preformed ideas about the meaning of mental health. Well, as an anthropologist, I should have been pleased to hear Summerfield say, and furthermore, why is medical anthropology not the hottest issue in global mental health today? In the current issue of Anthropology Today, Melissa Leach, a social anthropologist and the director of the Institute of Development Studies at the University of Sussex, writes an editorial about the increasingly visible role of medical anthropologists, both local and international, in shaping global health responses to infectious disease emergencies and humanitarian crises. In the context of the 2013-2016 West African Ebola outbreak and the current ongoing Ebola and measles crises in the DRC, in Eastern DRC, however, she offers a cautionary tale. In the fields of development and global health, anthropology is often seen as a magic key that can unlock the mysteries of quote-unquote local cultures. Our community-engaged research methodologies are often borrowed, yet applied uncritically, and without the attention to historical and structural features that shape local contexts and local behaviors during health emergencies. So this further entrenches the gap between global health governance systems delivering resources and the local community tasked with deploying those resources to halt an outbreak, for example. In all of this, however, we should pause to remember that anthropology itself, since its inception, has been a colonial project. Anthropologists, with their research tools for knowledge production and extraction, were essential to the success of the colonial expansion of Europe and the violent displacements of Native Americans in North America. Anthropologists were positioned as the objective scientific outsiders who measured, surveyed, interviewed, and defined the local subjects for the benefit of colonial domination. As a discipline, we are aware of our odious roots and our continuing relationship to the darker side of modernity, to borrow Walter Mignola's term. And as a result, anthropology has been critically examining the field and ourselves since the 1970s. Despite that, unsettling issues within our field continue to pop up and to remind us how far we are from decolonializing ourselves and the discipline. For example, the recent controversy last year over the misappropriation of Maori concept to name an academic journal without consulting Maori communities or scholars on the indigenous meanings of the concept. This is deeply ironic since the concept, how, is about reciprocity. Paige West at Columbia University has very powerfully written about anthropology's appropriation of indigenous concepts to develop our discipline. Carly Kutzi, editor-in-chief of the Journal of African Cultural Studies, recently reported on a panel discussion at the 2018 African Studies Association meeting in the UK that brought together activists, scholars from diverse backgrounds to discuss North-South academic collaborations. Panel participants problematized key words from the English language, such as decolonize, collaborate, ethics, and positioned them as points of conflict, debate, and even theft. Grace Musella at Stellenbosch University in South Africa argues against collaboration. And quoting the Kenyan writer Keyura Macharia, she writes in favor of, quote, wandering off rather than participating in workshops that only perform ethical collaboration. So clearly the task is not complete, and in fact it can never be complete. Yet this should not dissuade us from embracing it. And finally, this is the message that I want global health to learn from anthropology, that all of the features of global health, its ideas, methods, research questions, approaches to collaboration, interventions, all emanate from and continue to be enmeshed in our own historical relationship to colonialism and scientific imperialism. We must first recognize and then acknowledge that relationship, and then begin to critically and reflectively understand implications for our practices going forward. Always keeping in mind how difficult, perhaps even impossible, this charge might be. So towards that goal, we've invited leading scholars and practitioners here today in the hopes that by the end of the conference, we will all have a better understanding of the theoretical, methodological, and academic educational frameworks that can help define and perhaps set into motion decolonial processes in the field of global health. And also that we will leave here with a rich set of case studies within which to situate our new knowledge. Thank you, and I'll hand over to Yadu.
Thank you, Dr. Stewart. My name is Yadushini Ravindan. You can call me Yadu. And I'm here on behalf of the Duke Decolonizing Global Health Working Group. And I'd like to welcome you all to Duke Decolonizing Global Health 2020. It feels a little surreal to be standing here today because it took us 2.5 months to put this conference together, which if you're in this line of work, you know that's almost nearly impossible. But we had a small town helping us. I'm not going to say village, I'm going to say town, to put this together. And I'm extremely grateful for my co-organizers, Laura Makumba, Andrea Corris, Ali, and Cordelia. And I'd just like to share a few words about how we started this and why we want to do this here today. So I'd also like to take this opportunity to thank our incredible speakers here today. for their time and the effort to make it here from all over the world, all corners of the world. So it's really a true honor to have you all here today, and I'm excited for the next few hours. So together with my peers and amazing friends, Laura and Andrea, we co-founded the Decolonizing. I think I'm just going to talk, if that's fine. Or use the mic? Oh, okay. Thanks, Courtney. So we co-founded the Duke Decolonizing Global Health Group in 2018, following a conversation on our second day of classes. And our discussion mostly centered around our experiences living and working all around the world. But more than answers, what we had was an abundance of questions. Why does our training in global health start in the 21st century? Whose voices do we hear when we talk about global health? How do our histories of colonialism impact the work we do today? And for me personally, this topic goes beyond just the realms of academia. I believe that the time is right now, more than ever, to converse about moving forward in the global health field while acknowledging our colonial past. We don't believe a few hours today is going to magically provide a solution. It's a process that's going to take many years, just as global health has taken several years to develop. However, we hope today we get to continue this important conversation, ask important and often uncomfortable questions, and reflect on the spaces we occupy as students, researchers, practitioners, trainees, etc., in the global health field. So before we get started, I have the unfortunate role of talking logistics. So the main entry into this auditorium is right there where you entered. And in case of an emergency, there are 5 exits with all the signs lit up. The washroom is on the left of the auditorium, but out of respect for the speakers, I would like to ask you to please use the main entrance exit, and you can move towards my left to access the washrooms. We have 5 lovely ushers who right now I think are all over the place, but they're waving. And everyone's wearing a lanyard. So if you need help getting out or you need help at all, they'll be there to guide you. You can ask them or any one of the organizers with the lanyard to help you out. And out of respect for the speakers, I would like to ask that this is a technology-free zone. Please put your phones on silent if you don't mind. And next, we were supposed to have Darian Hun, an undergrad here at Duke University, to deliver the land acknowledgement. Unfortunately, she has met with some car trouble. So I have Dr. Amy Hurtle, who is also a member of the Lumbee Kohari tribe, Chief of Staff to the Chancellor at the University of North Carolina, Chapel Hill, and one of our fantastic speakers here today to give the land acknowledgement for us. Thank you.
Thank you very much, and it's quite an. I wish Darian were here herself to offer this land acknowledgement because she has written it herself. I'm going to read her words, but I will tell you, as a native North Carolinian on this land, it's quite a pleasure and an honor to be able to offer this land acknowledgement at this Global Health Conference. So I'll begin. A land acknowledgement is a formal statement that recognizes and respects Indigenous peoples as traditional stewards of this land and the enduring relationship that exists between Indigenous peoples and their traditional territories. Today, the land is an expression of gratitude and appreciation to those whose territory we now reside on, and a way of honoring the Indigenous people who have been living and working on the land from time immemorial. It's important to understand the long-standing history that has brought us all here to reside on this land, and to seek and to understand your place within that history. Land acknowledgement does not exist in a past tense or in a historical context, as colonialism is a current and ongoing process. So therefore, we acknowledge that this space is greater than a university, and the space that the university now gathers on, though, is land that has long served as a site of meetings and exchange amongst a number of people, of Indigenous peoples. Historically, they were the Shakori and the Catawba people. It's also important to recognize the 8 tribes that currently reside in this state and call North Carolina home. These include the Lumbee, the Coharie, the Meherrin, the Occaneechi Band of the Saponi Nation, the Halawa-Saponi, the Waccamaw-Siouan, the Saponi, and the Eastern Band of Cherokee Indians. We honor and respect the diverse indigenous peoples connected to this territory on which we gather. Thank you.
So I'm going to moderate the first panel, and our first speaker is Walter Mignolo. Come on up. He's a professor in the literature program. Whoops. There we go. In the Department of Romance Studies here at Duke University, and he has a secondary appointment in the Department of Cultural Anthropology. Our speakers, it's a four-person panel. Everyone has 15 minutes, and then we're going to have a... Yeah, okay. Is this better? Okay, apologies. We have 4 speakers on the first panel, and everyone has 15 minutes, and then we're going to have a Q&A, and plenty of time for the Q&A. So I'm going to hand over to Professor Mignolo.
There you go. Okay. Well, thank you very much for the invitation. We have 15 minutes, so I will be too long. Thank people and all these kind of things, but I am glad to be here, not because of what I have to say, but because what I would like to hear from people who are involved in global health. So I will say probably something about decolonization, decoloniality, and I hope that what I will say will be of some help for the conversation. I will not make an argument because I have 15 minutes, but I will make some points to make an argument. So this is kind of puzzle, so you have to kind of connect the dots. And that might feel better, because if I argue, you just kind of sit there waiting for the conclusion. In that case. So I will start with, now, this is not the last one I am. Because I sent 5 copies to Laura this morning, and I said, this is the last one. So I will say something about coloniality, colonization, decoloniality, while you read this text and you read it. Right? I won't comment on the text, but instead of university, think about global health. Just change. And I will, in the meantime, I will say something about the global. You should know first that I come from the South. So my body, my mind, my perception, my feeling, my emotion, my senses that kind of inform my reasoning come from the South. I lived 26, 27 years in Argentina and then went to France, but I mean 26, 27 years. It lives in a mark that you cannot forget. So when we talk about the global, for us the global started in 1500. It's the first time that the globe has been mapped, literally, cartography. You don't have a world map as you see it today until 1500. So the global was since in the move. The conversation about globalization is recent. And not a globalization, I would say that is globalism. And I think that started in the 80s with neoliberal talk. So trying to get away from the nations or the global, etc. And trying to neoliberal projects. But that was not globalization, but was rather globalism. So when we talk about global health or whatever, but let's say global health, we have to keep in mind what are we talking about. Are we talking about the people get sick in the world? They always did that, right? Animals and people and plants, they get sick. Always have been global before 1500. But since 1600, people began to connect easily through the time through the technology, the boats, the railroad, the airplane, etc., etc. So that is what we talk today about global health. And we see now with China, I mean, that kind of spread quite quickly. So, but when we talk about global health, we talk about two things. We talk about what is going on there in the globe, in the planet. That we call that in semiotic terms, we call that the enunciation, what we talk about, the content. But on the other hand, who talks about global health? So the enunciation cannot be global. The enunciation is always global. So the question is then, who's thought about global whatever, global health, and what for? What is the purpose? And I think it's very clear in the statement of this conference that the global health is part of the largest picture of the local histories on the West, trying to design and implement global design. So I think that as we see now, in the overview, we can talk a lot about global health. And when we talk about global health and make that kind of distinction, what we want to decolonize is not global health over there. What we want to decolonize is the discourse, the narrative about global health, and in which narrative are we embedded? What kind of political responsibility are we taking? And that is one of the statements made in the announcement. So the enunciation cannot be global. Enunciation is always local, even when that enunciation is in the United States. In China now, we can see that we talk a lot about global health, but all of a sudden there is an emergency and got to be taken care of, and that taken care of is local. And apparently, China has the condition and the responsibility to take care about these kind of things. And I was reading this article about Pepe Escobar, about all the measures that the China state is taking to stop this spread. So the main point is that number one, the globalization is since 1500. What kind of globalization we have since the 80s? And in relation to that, what does it mean to decolonize? It's not obvious. Today, everybody and piece of their family is decolonizing everything. And that is good. There is passion, but at the same time, even if there is a lot of passion there, I think that there is a need to think differently about these kind of radical changes in the world. We are no longer living an epoch of change. This is a change of epoch. And we don't have concepts because we have always thinking in changes in a kind of linear way. So the concept of global now takes another meaning because it's no longer the West, we're talking about the global. And we have to listen. So the question of humbling the discourse about the global, especially from the West, and I mean this Western Europe and the United States, or the North Atlantic, that's when I talk about the West. Or if you mean, you have a longer history, the West of Jerusalem, because North Africa, Maghreb is also the West, that is the West of Mecca and Medina. So these are my, I have 3 points, I forgot, 3 points in 15 minutes, I hope that 5 minutes per point. So this is my first point about globalization, about coloniality, about decoloniality. coloniality, and let me say one more thing about this first point. Because in the announcement they say colonialism and neo-colonialism. That is a linear way of looking at it. We, when I say we, it is the people who began to think about this kind of things in the South about 30 years ago. We don't talk about neo anymore, because that is a linear. As a student of mine put it beautifully, and Samantha Hong from the Unity School, about 3 or 4 years ago in my seminar, trying to understand what is going on. And she said, coloniality is not over. It is all over. So there is no neo-colonial. It's the same logic of coloniality that for 500 years has been underlying the foundation and transformation of Western civilization. So that's a big statement. I don't have time to defend it, but I would say that coloniality is the underlying structure of Western colonization, as the unconscious is the underlying structure of our psyche. Okay, so that's my first point, and I think I'm going well here. So my second point is something about health. Only here 5 minutes. I started 5 minutes ago. Well, my second point, I want to say something about health in relation to what I said before. And that is coming with the conversation with Casey McDermott, made a kind of PA thesis with me. And so she was doing work in Guatemala. So to give you, this is not a thesis, that's my own kind of text, because I'm doing also work on the kind of Maya cosmology. So what is important here is, what does it mean, health, for the indigenous women in Guatemala? How do they talk about healing? Because the question is just not physical health. To go quickly in the next 2 minutes, is the colonial wound that affect them, affect many people, but I'm talking about the sanador. So the question of healing is not just physical, it is psychological, it is spiritual. And the question is to reconstruct that way of living, that way of the balance with the universe, with the kind of the community, in which healing is not just the healing of the body, it's the healing of the spirit, because we know if we don't have love, chances are that we get sick. So a lot of sickness are cured by love and not by pharmaceuticals. So that is the Red de Sanadoras, is an organization of indigenous women, and that is not New Age, that is very political. It's very political because they have to confront precisely global health coming from the north. So for them, global health is a problem, because they kind of prevent them to do what they want to do, and they are trying to tell them what to do. So that is what is changing now. So I think that the term of globalization now is that the locus of enunciation of many people in the world at many levels, the state, but also in the public sphere, is kind of emerging, re-emerging. So that is my second point, is the question is to pay attention and listen to what are the needs of people that have been disturbed by coloniality and perhaps continue to be disturbed by global health and other kind of globalization to tell people what to do. Can I have 2 more minutes? Okay. So I went very quickly my second point. I go to my third point, and I just want to give you a quick idea of what do we mean by coloniality and the colonial nature of power, the kind of the structure, because to talk about the coloniality without knowing what coloniality is and how it works, we cannot get into the dark, we can get lost in the forest. So we need an analysis of coloniality in order to orient our decolonial work. So the colonial matrix of power for these are some basic terms that I will just go over because I don't have time. But the colonial matrix of power for us, the way we are working, and this is a map. It's not to be applied. When you get the map in the city, you know a little bit or you don't know. The map guides you. And when you get to the place, well, the place looks very different from the point in the map, right? So this is a map. It's not a model. It's not a model to be applied. So the colonial matrix of power has 4 domains: knowledge and understanding, governance, economy, human and humanity, the model of the human that has been built since the Renaissance. So those are domains. That is what we talk about. These are the contents. And in the center, we have the same. So in the margin, we have what is being said, what is being taught. In the center is what controls the said. And what controls the said is the same. You don't see it, but it works. And we call that the enunciation. That is kind of control of knowledge. You control knowledge, you control subjectivity, and you control global health, and you control economy, and you control everything. The question is the control of knowledge. So we call that the constitution of the colonial matrix of power. So the constitution of colonial matrix of power we call modernity, we call Western civilization, but when we look into that a little bit more, we began to see this because this appeared in the discourse themselves of Western civilization. In the discipline, in science, etc., in the news, in the common knowledge, etc. So what I want to, just 2 more minutes, this is the Constitution, but there are a simultaneous movement at the same time, and this began to be built in the 16th century. It's not in Greece. You cannot find it in Greece. And the same movement of constitution is the movement of destitution. So, communal wisdom is destituted, living in harmony and plenitude is destituted, communal economy is destituted, and lesser human races, sexes, nature are destituted. And that is the work of the kind of enunciation. So we have to think about, when we talk about global anything here, that is the constitution and the kind of the transformation of the constitution, the colonial matrix of power. What is being destituted? What is being silenced? What is being left out? What is not being heard? So that is the question of the destitution. How to respond to that? And there's a lot of things going on now. Is with restitution. And restitution requires epistemological and aesthetic feeling subjectivity reconstitution. So the task of the colonization, now the coloniality, is epistemological and aesthetic reconstitution in every domain and the enunciation of the colonial matrix of power. That cannot be one model. It needs a lot of projects, a lot of people who kind of are working on that, and thank you very much for the extra time.
Again, it's a pleasure to be here today with you all. I'm glad you can hear me. So the title of my talk is Inclusion in the Academy. I think it follows up very nicely with our previous speaker as we think about and just heard about, I love this quote, colonialism is not over, it's all over, right? And destitution versus reconstitution. I'm going to lean into the reconstitution space right now, primarily as it applies to the academy where I spent most of my professional career. I would like to say very quickly, I don't think I did it when I read the land acknowledgement. I do want to truly thank the student organizers of this great event for bringing us all together here for this conference and also around the globe. It's quite a feat that you've pulled off, and I know that's a labor of love. So I want to thank you all for that. And I'm hopeful that this talk in my 15 minutes of time here will have something for students, for faculty, for researchers, for staff, and for any administrators that might be listening to us or joining us on this day. So briefly, this is what we're going to go through. I'm going to talk with you about my lens, my perspective, the way in which I've approached this time that we have together. I'm going to define the term inclusion and why. We're going to talk briefly about why it matters. And then I've got one slide on the history of education for American Indians, right? That's a whole lecture in and of itself. But the colonization of education and what we're trying to do in this in higher ed today to decolonize spaces for American Indians, but also for other groups as well. Efforts that we are currently engaged in at UNC Chapel Hill to enhance inclusion. But on the flip side of inclusion is exclusion, right? We know that when we see it. And I want to talk briefly about some of the books that are out now that talk about the impacts of exclusion in the academy. And then finally, I'll summarize it with just a few lessons learned. So briefly, I am an Indigenous woman. I am Lumbee and Coharie, here from this very state. I'm an enrolled citizen of the Lumbee tribe of North Carolina. And my background's in social work and law. So I have my MSW in social work. I was very much drawn to self-determination, how to foster and enhance the self-determination of people and people groups to engage in society, in especially marginalized groups, to have access and engage in society. And law, which I practiced for 5.5 years, very much interested in how laws are structured, how societies are structured, and those laws that govern people's access to navigate the world around us. My research area of interest is asset building. I take a holistic approach of looking at assets, even though the area that I studied was financial asset building, but we know in Indigenous communities, assets are well beyond finance. They're cultural, natural resource, human, political, social, and so on and so forth. And then I'm now spending my career and time in higher ed. I am faculty in our School of Social Work at Carolina. I'm also, as was mentioned, Chief of Staff and have served as Director of the American Indian Center at UNC. So here you just see some very quick Oxford Dictionary definitions of the term inclusion. There's a noun, an adjective, and a verb there. But what I'll just say briefly about it is inclusion, summarily you can see it, right? You can feel it. You can actively offer it to others. But most importantly, I think we know when it's missing. Sometimes it's hard to put your finger on it, but you know when it does not exist. So then the question becomes, well, how do we truly see it? How do we know it? How do we know when we've arrived at inclusion? Who gets to make that determination? Well, I offer that I believe it's partly defined through the self-reflection of the group that is trying to extend the inclusion, taking a step back to really question, are we really truly trying to include others? And by that I mean, are we willing to share power and privilege in the space that we're inviting others into? And I believe it's also partly defined by the self-reflection of the group that is trying to be included, or the group that has historically been excluded. So the question could be, do I feel included? Going back to that feeling. Do I have access to that privilege and power in this space? Is it being shared? And do I truly believe that? So why does it matter? Well, from a social justice perspective, it is just and right, for people to have access to systems that allow them to better their lives. It improves problem solving, and I'll tell you, corporate America has figured this out. Corporations have figured out that to impact their bottom line, they need diverse teams, because diverse teams challenge each other, they ask diverse questions, and they get at different types of answers. Inclusion matters because it can influence change. Again, those different questions, those different backgrounds do lead to different answers, and those different answers can lead to change. And then it's just right. You know, the basic, it's just right. Exclusion is not. Inclusion is just right. So my son turns 9 today, so this picture of this little boy is it hurts, as it should for all of us. This is an image there that you see on your left of what education, colonized education, was like in this country for American Indians. This is an image of a young boy that was taken in to a boarding school. And the policy in the boarding school era of our history was kill the Indian, save the man. It's a policy and a process of assimilation. Well, as we heard earlier, right, colonialism is not over, it's all over, right? We have these huge institutions today of higher ed that we participate in. But I can tell you in American Indian communities, on college campuses, we are doing what we can to decolonize the spaces around us, to make the experiences truly unique and our own, and to create the inclusion where we feel like we have often been excluded. So here's an example of some efforts that we've been engaged with at Carolina. Since the early to mid 1990s, UNC has heard from many student groups, as well as alumni, who have been advocating for the creation of centers, student-based centers. And when I was there, the big push was for what was the Multicultural Center. Eventually became the very first Sonia Haynes Stone Center for Black History and Culture. That became our very first center. And since we've built many other centers on campus, I, as a student leader at Carolina, was advocating for an American Indian Center. And over the last nearly 30 years, we have developed many other centers, including the Carolina Asian American Center, which was passed just yesterday by our Board of Trustees after over 20 years of lobbying and advocacy. So we're very happy for that. But you know, I'm going to talk about why these spaces matter, but I've heard people ask, wait a minute, are we just resegregating the South? All these centers on our campus, are we just creating pockets of places so that others don't have to engage with one another? And my argument absolutely is that is not true. These spaces are places where students go, faculty and staff, to be themselves, to re-energize, to regroup, so they can go back and connect to the broader community. I think our task now in higher ed, and at Carolina, truly, is to figure out how to take these wonderful spaces and places where our people go to re-energize themselves and reboot, how to weave all of that together, put those pieces of the puzzle together so that the broader community, everyone feels like they've got this space in the broader community. There's an inclusion across, regardless of any barriers or boundaries. So I have a couple of texts here I wanted to share with you. The first is this Beyond the Asterisk, written in 2013. It's an edited version, many different chapters here. But I love this book, and if you haven't seen it, I do encourage you to take a look at it. The basic premise behind the book for American Indians is if American Indians are left out of the data collection, if we are reported with an asterisk in studies, because size, insignificant sample size, then we are left out of any analysis of the problem. We're left out of identification of new problems. We're left out of the identification of solutions, resource allocations, and even classroom content and curriculum. And then the vicious cycle continues. This book does an excellent job at articulating not just research, but also some of the things I talked about before with respect to space for students. And here's another text. This text, Toxic Ivory Towers, just released in this last year by Dr. Zambrana. She's coming to campus, actually, to meet with many of our leaders and students in the month of February. But this book we read with the Chancellor's Cabinet and with the Provost's Leadership Cabinet as well. It's really talks a lot about the perspectives of faculty of color in predominantly white, but I will call historically white institutions, right? Carolina, many of our other institutions are historically white institutions, and the policies, the structures, the spaces and places we navigate were created at a time when the majority culture was white. And so this book talks about the faculty perspective and invisible work. Faculty of color, primarily, are taking on invisible work. Our students seek us out because we look like them, right? And we've made it or gotten through something that they might want to, they're trying to achieve and get through successfully themselves. So we take on mentors, students as mentors, because it's, again, the right thing to do. But it's invisible work, and it's not seen most of the time, many times, by other faculty, by chairs, by deans. The cultural and identity tax. This tax often falls on faculty of color as well. It is the service on task force, commissions, search committees, always being the one called to do some of the work that truly makes the university kind of go round in the service space, but not getting the adequate, really fair credit for that service in the academy. Microaggressions, which can happen within departments and schools and units, maybe entirely unintentional, but it slights, its lack of knowledge and understanding of other people's cultures and saying words and things that, quite frankly, aren't illegal, but really do impact a person's experience in the academy. And then I'll just talk for a moment here about devaluation of research. I can tell you that when I've engaged in the research process, I've done so in areas that I thought would be beneficial to the communities that I come from. I want my work, my research, to give back to the people who gave so much to me, for me to be in the spaces that I'm in. However, those journals aren't always the journals that the Academy values. And this text goes into a bit of that, just the devaluation of research that may be important to us, but isn't as always as important in the Academy. So what's the impact of all of this? Well, there is race-based stress. It's that sort of stress that people of color carry that others don't have to carry around the academy. College is stressful. The university experience is stressful for all students, but there's an added level of stress that students of color, faculty of color can feel. We heard this echoed at a recent summit on safety and belonging that was held at the university actually just this week. And we heard this from faculty, staff, and students. Just think of the built environment, right? This has been all over the news in universities here in America. Buildings, the names that are on buildings, right? The names of spaces and places that we have to traverse. That history attached to that can carry a stress that others don't always have to navigate. This hypervigilance and awareness of identity, I'm always mindful to name my communities, my tribes. I'm very proud of the tribes that I come from, but I don't represent the over 500 tribes in the country, right? So I speak from the perspective that I've been given and that I've had. And then we certainly have heard an interest and an increased need for mental health services from our different campus communities as well. And then I just want to say, just for a moment, we need to be careful that as marginalized groups, we don't marginalize other groups, right? What's done to us, it's kind of human nature to end up doing it to someone else. But remember, the socially just thing, the right thing to do is not to do that to others. It's not about a parade of terribles. These terrible things happened to my communities in my history, and they may have been worse then or not quite as bad as maybe the terrible things that happened in yours. But folks, we're all impacted by colonization, and it's about understanding how that impacts us all differently. So here, finally, lessons learned. It takes community to build community. At our 2019 Thinkposium, which is just a day of learning around issues of inclusion and diversity on campus, the theme was voice. And really, everyone has a voice. And we need to find ways to include others' voices in the conversations and even in decision-making that's happening around campus. It's important to remember that people build culture. People build climates within that culture, right? And so to change a climate within an institution, within a school, within a unit, it really does take working with people on that very, very local level. We can only be our best selves together. Sometimes it takes those separate spaces and places to reconnect, to build ourselves back up, so when we go back in the broader society, we can all contribute in much stronger and better ways. And then inclusion is physical, mental, spiritual, emotional. We can feel the stress on our bodies. We know when we're physically in a place or not. It's about how you're feeling spiritually. And emotionally, it's mental health, right? Inclusion it impacts the whole being of us. And then I added last act, because even failure is learning. Folks, we have to try and keep working at inclusion. It doesn't just happen. We're not just going to be there and achieve it. This work is very hard. It doesn't come natural, but the effort is quite worth it. Our history has certainly taught us about what exclusion for many of us feels like. But we have to sort of pull the curtain back to start looking behind that to see, well, how do we reverse? How do we move into inclusion? So I'll ask, what does inclusion look like? I don't have it all figured out. We certainly don't, but we're trying. And that's what I encourage you all to do in the spaces that you transverse and that you work in each and every day. Thank you.
Thanks, everyone, and I'm very grateful to the students who've led this conference. I'm also fascinated that these series of conferences that have been happening for the last couple of years have all been led by students. Not quite sure what the adults are doing. But it doesn't surprise me that the same is happening with climate change, gun control, and whatever the youngest people are thinking clearest, is my take on it. Why am I giving this presentation, and what perspective do I have? So I would say that I have seen the world of global health, whatever it is, from both sides. For 30 years, I lived and worked in India, where I was born and raised, and I did research, which I never called global health. I just did research, right? I worked on TB, malaria, leprosy, diarrhea, whatever I had to do to survive in my job. And now, having moved to North America, where I've lived in US and Canada, whatever I'm doing now is called global health research, right? And I'm the director of global health, for Christ's sakes. So in some ways, I'm kind of perpetuating what I saw from the other side. And over the years, I've started to see and feel uncomfortable by what I'm seeing as the world of global health. I'm starting to write about it. I'm starting to talk about it. And this is the first actual real lectures I'm giving on this topic, but I'm writing about it and I'm thinking about it. I'm doing small bits of research, which I'll show you in a second. So and I'm not a theorist. I definitely don't have any history training, nor do I work in colonial scholarship. That's not where I come from. I'm a very pragmatic global health researcher who's actually seen some things. That's what I want to share with you, and we'll see how it meshes with everything else that we're going to hear from here. So there are two things I want to start off, two statements that I'm sure every single student in this room has either heard in a global health lecture 101 class or read in a global health textbook or whatever. The first statement that we all make, and I've made them too in my class, Global Health 101 class at McGill, is that global health is a much better version of colonial medicine. We've come a long way from whatever happened in the past, but the current iteration is something that we are all happy and comfortable with. Yes, we do acknowledge the colonial, the tropical medicine and all that stuff, but today we are in a much better situation. That's the first statement. Are you all familiar with this? Have you seen this being said and repeated? Perfect. Second statement is that equity is at the very heart of global health. If there is no equity, then there is no discussion around global health. This is repeated again and again. It's even included in whatever definitions of global health that are flying around the place, right? So two statements. One is that we are far, far better than the colonial medicine past, and that global health is all about equity. And now I want to challenge these two statements with some data, okay? These are not my personal opinions, they are data. And then I will end with my personal reflections. But I want to first hit you with data because I'm an epidemiologist, okay? So the first piece of information, and I have 5 exhibits to share with you. It's a work in progress, and I would encourage students in the room to do more of this kind of research so that we can expand this evidence base, so to speak. The first thing I want to ask is, who sets the global health agenda? Okay? And to answer this simple question, I have different sources of data because there is no one way to capture this. First piece of data I want to show you is the Global Health 50/50 project has been cataloging what is happening in terms of gender balance in global health and so on and so forth. But thankfully, they've also put out this infographic. They've looked at 198 global health organizations, WHO, Gates Foundation, you name it. They've cataloged all of them, and you can see this long list of different groups. And they've asked a simple question, where are they headquartered? Okay? And if you look at the map, it jumps out at you that nearly 90% of major global health organizations are headquartered in Europe or North America. Okay? Now, you know as well as I do, wherever the action is, that's where the agenda gets set. So agendas in global health are set in Geneva, they're set in Seattle, set in New York, they're set in London. Very predictably, as you would imagine, it would have happened 100 years ago. Right? There's very little activity, agenda setting from this perspective happening in LMICs. You must excuse me for using the dichotomy of HICs versus LMIC. I'm very painfully aware that the world is much more diverse and complicated than that. But for the sake of 15-minute presentation, I'm really dumbing it down to the dichotomy, okay? All right, second exhibit. Although Global Health 50/50 is not yet done it, and they hope to do it next year, I also asked a simple question, if I could get a composition of the boards of these 198 organizations, that would be beautiful, right? Who is around the boardroom to set the agenda in these organizations? Unfortunately, they don't have it, but they're working on it. For now, I had one of my students, Lavanya, look at the board composition of 15 really important organizations, okay? Institute of Health Metrics and Evaluation, TB Alliance, CHAI, PAP, Wellcome Trust, Gates Foundation, Stop TB, United, Global Fund, Gavi, so on and so forth. And the marquee finding is 75% of the board members are based in high-income countries. Okay? Based, living and working out of high-income countries. Third exhibit. Lancet puts out all sorts of commissions. I've been part of 2 already. Okay? And they are quite influential because they try to set the agenda, so on and so forth. So I had another student of mine pull out all 59 published Lancet commissions, not including the ongoing ones, and asked a simple question, who is leading them? Where is the corresponding author based? Which institution? 90% are led by folks in the high-income countries. Okay? Next, who is paying the checks? Right? Who is funding global health? And there is no better piece of data I can come up with than what the IHME has put out. And predictably, United States is the biggest funder of global health, followed by UK, private philanthropy, Gates Foundation, Australia, Canada, France, Germany, and bits and pieces from others. Right? The money flow is exactly what you would imagine, what would have historically happened. It's predominantly high-income countries that fund global health, and you and I know that whoever gives the money controls the agenda, right? That's also very important to know. Next, who is publishing global health research? Here, there's been a flood of fantastic research by a whole bunch of people who I cannot name or individually credit, but you can see I'm just giving you a slice of the data. There's even more papers that I could not possibly fix on one slide. Study after study shows exactly the same finding. And I'm going to pick this paper, the title of this paper, Stuck in the Middle, as the most succinct way of expressing what happens to research that is done in LMIC. The LMIC folks are stuck in the middle. They're neither the first author most of the time, nor are they the senior corresponding author. They are in the middle. If at all they are on the paper. That's no guarantee that they will be on the paper. I've seen publications where the entire research is done in LMIC. There's not a single LMIC author on the paper. But when they do make it on the paper, they are in the middle. Okay? It is completely agnostic to which research area, which LMIC you look at, which journals the data are published, same consistent finding. Next, who is editing global health research? So again, a few students and I looked at this. We looked at 12 global health journals where the journal title says global health or says international health. Couldn't get easier than that, right? Any journal which had global health or international health in the title, we looked at the editorial board composition. Another group from India did exactly that on a wider sample of journals. About a third of the editorial board is from LMICs. And there are very few editors-in-chiefs who are actually from LMICs. Okay? So the journal editing is predominantly done by folks in the richest part of the world. Okay? Most global health journals are headquartered in London even today. And if it's not London, it's New York or Seattle or Baltimore, but it is not Nairobi or New Delhi. Okay? Lastly, where is all this global health research being shared? Right? To answer this question, I did a quick and dirty study of the biggest TB conference, the biggest AIDS conference, malaria conference, tropical diseases conference, and global health conference. Right? 80 to 100% of these global health meetings are held in the highest income countries. 100% of malaria conferences are held in Europe where there is no malaria. Okay? Try and figure that out for yourself. And these conferences are held in countries where you can't even get a visa to enter the country if you're from an LMIC. How do I know? Well, I had my US visa rejected the first time I applied in 30 seconds, so I know all about that. Okay? I know how traumatic and painful that can be, and this is happening as we speak today. So I invite folks from LMICs to come to McGill on my letterhead as a director of global health. My own government denies them a visa. How inclusive can I be when I'm holding meetings where I cannot even get my colleagues that I want to listen to and learn from? Right? How hard is it to get a US visa today? Or to go to the UK today? It's a nightmare, okay? That's why we hold our global health meetings. All right, I want to wrap up by telling you what I'm learning from all of this data that I've shown. There are many definitions of colonialism. We heard some of our speakers talk about that. One common theme that comes from the definitions is one of domination, right? And I think you would all agree with me. The data suggests that folks like us, all of us in this room, those who live and work in high-income countries, we dominate global health right now. Every aspect of global health, we dominate it. And the whole system is designed to benefit us, our trainees, our grants, our publications, our career progress, our ability to be influential on the world stage. The whole system, right from get-go, is biased towards us. And I think we all need to begin by acknowledging that this is an issue. Because if we care about equity, this is not how equity looks like. This is the opposite of equity. That's an important step to acknowledge. And I want to finish by saying, so what do we do about this problem? If we acknowledge there's a problem, what do we pragmatically do as individuals? So what do I do as a professor? What we do as a collective is worth discussing, and that's what this conference is about. I think we should all read some of the best people who are working in this area. Listen to conferences like this, because these are very valuable safe spaces to have this conversation. And I hope we'll have more safe spaces to talk about this, because most global health programs are currently not even thinking about this, right? So how do you acknowledge when there is no space for you to even have this conversation? And I also think every global health course that is taught needs to be taught more critically. Not that global health is flying into some country and saving poor people, but to acknowledge and start off. So no global health course should begin without an entire lecture or module on colonialism, right? There are global health textbooks that don't mention colonialism, right? So you need to ask yourself, are we teaching our students a critical approach to global health? You need to do small bits of research of the kind that I showed you. Document. Just like people working in women in global health are documenting that women are missing. We need to say people from LMICs are missing. And that is how we're going to expand this conversation to look at intersectionality and make sure we are more inclusive than we are. Practice reflexivity is very hard. It is so hard to be reflexive. When the entire system is benefiting you, you would rather not rock the boat, right? So for me, reflexivity would mean that was me. I don't know if you can even spot me in the corner. That was me as a young resident in Vellore in India, and that's me running around in a leprosy van in the villages of Tamil Nadu. And I did what I did, and I saw young people from America and UK come to our little town, stay for 2 weeks, go home and publish papers, when none of us published a thing, right? And I think I was worried about it then. I couldn't articulate it, put my finger on it. Now I do after reading Shay's paper on the foreign gaze. I think I was upset that foreigners were getting to do things that we could never do. And then now I'm perpetuating similar things by sending McGill students to go all over the world. And I need to be very reflexive about this and ask myself, am I doing it right? And then leaning in and leaning out. So all of you know Sheryl Sandberg's book, Lean In. So I really think the time has come for our LMIC colleagues to really lean in. So there's a malaria meeting. I want to hear from Africans dealing and working on malaria. I don't want to hear a European talk about malaria, which means they lean in. But can they lean in if we don't lean out, right? Should we actively practice the art of leaning out to create space for people with the best lived experience, people who are closest to the ground, closest to the solution, closest to the problems, to have a greater say in the agenda, to dominate in lectures and writing, which means should we actively lean out? And there are big structural barriers for leaning out. Will my university promote me if I'm a middle author? Right? Will I get grants where I'm playing a more enabling role than in a leadership role? Huge problems that are structural that we need to worry about. The biggest structural issue I'll end with is this massive inequities that we live in. This has got nothing to do with global health and everything to do with global health. If a bunch of billionaires own as much wealth as half the world's population, how do we even tackle the structural problem? And we need to really start doing the kind of work that Anand Giridharadas and others are starting to do. Challenge this question of how much wealth is in the hands of so few people, and why haven't we as a society even demanded that there's some accountability to this so that we can actually fix the underlying inequities of this world. Okay, with that I stop, and I'll be happy to take any questions on the panel. Thank you.
So now we go to our speaker in Geneva, Maleki Kayesi, who is the technical officer, as you can see here in the Department of the Social Determinants of Health. And Maleki, can you hear us?
Thank you. I
Great.
trust you are all able to hear me.
Yes, we can, and you're most welcome.
Thank you. I'm grateful and glad to participate in this panel on decolonizing global health. The focus of my conversation is on harvesting and utilizing tacit knowledge in national public health policy planning. Next slide, please. I have three aspects to cover in my conversation. The first is that the issue of decolonizing global health and the use of tacit knowledge needs to be contextualized within the political economy of knowledge production and policy development. As Menaka has stated, tacit knowledge is highly personal, deeply rooted in action, context, experience, practice, and values. It's acquired by experts over a long period of career. It consists of technical skills, mental models, beliefs, perspectives, and is so ingrained that we take it for granted, and we find that sometimes we don't articulate it easily. This form of knowledge contrasts with the explicit knowledge that is codified and found in databases and published documents. So decolonizing global health is essentially a call for deep reflection on the question, whose knowledge of reality matters. The concern about whose knowledge matters is found in several academic disciplines, including development, environment, history, and health. I'm glad we've seen it from history, from literary works, and my colleagues who have just delivered their lectures. I'll take the example of Robert Chambers, who has been concerned about the professional expert who drowns the local knowledge in rural development planning. He has challenged this inequality in development knowledge and provided tools for capturing and using local knowledge in development planning. Next slide, you can see the work that Robert Chambers has done. I'm sure you are familiar with the works of Ngugi wa Thiong'o, Decolonizing the Mind, and Howard Zinn, an American historian, who has actually given us the history of America from the people's perspective. And from my own discipline of transport, we have colleagues who are making an effort to challenge the knowledge that is essentially from the north. And of course, we have efforts by groups like the UNESCO trying to gather the local knowledge. I'll devote a few minutes to the experience of Robin Warren and Barry Marshall, whose discovery of bacteria as the cause of peptic ulcer reveals how valuable experiential knowledge of an individual can easily be systematically ignored and suppressed by the dominant narrative if this knowledge does not find an alternative of expression and release. In 1979, Warren, a young pathologist, noticed that bacteria, which later was defined as Helicobacter pylon, was found in patients suffering from stomach ulcers. Now, he later met Barry Marshall in 1981, and the two worked very hard and eventually confirmed that ulcers were caused by bacteria. As described by Chip Heath and Dan Heath in the book Made to Stick, this was an astonishing discovery with enormous significance. If ulcers were caused by bacteria, they could be cured by simple treatment with antibiotics. Naturally, as human beings, we'd expect such a discovery to be celebrated, but this was not the case because the medical world did not rejoice. Warren and Marshall spent many years trying to convince the medical establishment about the validity of their work. It's reported that when Marshall presented their findings at a professional conference, the scientists sneered at them. And one of the researchers literally walked out of the conference and made a statement to the effect that he didn't really have the disposition of a scientist. So we may wonder why this type of response or reception. It's been hypothesized that there are three main problems. The first is common sense. The conventional wisdom of that time was that the stomach was too acidic for bacteria to survive. The second was the source. These two young people were young. One of them was just a pathologist in a hospital in Perth, and the other one, this is Barry Marshall, was 31 years and just an internist. There's such a huge bias in the medical community, like other academic communities, where important discoveries are expected to come from PhD holders at research universities or professors at large and world-class medical centers. So at that moment, at that point, internists really were not expected to come up with such discoveries. And we've seen this in environment, for example, Rachel Carson with Silent Spring, Jane Jacobs with Death and Life of American Cities. Really, their work was virtually rejected. The final issue was the location. The city of Perth, where this discovery was made, was not seen as a very important site for research. And of course, it was expected that the solution, such great discoveries, will come from some other sources. So why am I belaboring this point? This story shows that in general, local knowledge, as well as experiential knowledge, that is possessed by those who appear to be weak can easily be ignored. We tend to respect and readily accept knowledge that comes from authoritative sources. Voices of the less powerful can suffer neglect. I've had experience, and a number of you, I'm sure, have done the same, to interact with health and development professionals at national and subnational levels, and they really possess great insights into how health and development issues can be addressed. However, several of them do not publish this knowledge, and as my colleague who has just presented before me, many of them don't attend key international conferences to share this knowledge. So this is where we are missing a lot. If you look at the work of Donald Shawn, he reminds us that acquiring experiential knowledge is crucial, and the practitioners really improvise and come up with solutions which are not necessarily based on book knowledge. The second aspect of my talk is that tacit knowledge is an asset, is such an important asset. The next slide, please. Tacit knowledge is an important asset that we should utilize for national health policy planning. Tapping into tacit knowledge is essentially drawing on the wisdom that individuals have accumulated over the years. If you look at the book of Ecclesiastes in the Bible, it reveals that there was a mighty king who came against a city. He surrounded it and was about to destroy it. But there was a poor wise man in that city, and he saved the city. Unfortunately, the story ends on a sad note that no one remembered that poor man. And this is what we are talking about, that individuals rise to the occasion and they bring forth the deep insights that should help us. Now, there's a knowledge conversion model that has been proposed by NONAC. For example, we can transfer tacit knowledge to tacit knowledge through socialization. This means when we live next to each other, we are involved in sharing experiences, observation, imitation, and thinking together. That knowledge can be transferred, what we see at the university, between a supervisor or a professor and a PhD student. But we can also convert tacit knowledge to explicit knowledge through codifying it. That means we write it down and make it available. And so I'm just pointing out from the slide that is up that there are ways that we can actually tap into this knowledge. The third and final aspect of my conversation is that the public health sector needs to invest in this great asset. We may ask ourselves, have we truly harvested this knowledge and made it available for planning? I have looked at literature, reviews, labs, programs, and efforts to show the state of the art and practice of harvesting this knowledge. And I've come across a study from Canada that has shown how tacit knowledge is utilized in identifying opportunities, in bringing teams together, and working programs details such as partnering and funding. We have guidance on how this can be done, and in different ways, different public health institutions and professionals are drawing on this knowledge. We can use mentoring, we can use peer-to-peer learning, meetings, conversations, storytelling, and when you do joint work, to share tacit knowledge. However, I've not yet found an example of a country or an organization that has developed an explicit method or process of harvesting this knowledge, or where there is a hub. And I'll continue to search, and perhaps should I come across it, I should be able to share with you or with some participants. So as I conclude, I'd like to leave you with this question to reflect on. The final, second last slide, please. The question is, has Duke University invested substantially in tacit knowledge harvesting for national health policy planning? As we think about decolonizing, are we really contributing to harvesting the local knowledge, the experiential knowledge that is available and can help us to challenge the existing dominant narrative in global health. I thank two of my former brilliant interns from Duke Global Policy Program, Kathleen and Sean, who have contributed in reviewing and providing helpful comments on my conversation. Thank you very much.
Okay, so thank you, Kayasi.
So I think to warm us up, I'm going to field some of the questions from Twitter, and then maybe some of you will get inspired to ask some of your own questions. Okay, so from our friend and colleague Shashika Bandara, brings up a question. Dr. Mignolo brought up an interesting concept, the colonial wound. What is the role of colonial wounds in the current world, and how do we heal from it? And for all of the panelists, how does global health as a system heal or further hurt colonial wounds?
The problem with Corey is that she took a seminar with me, so we continue the conversation here. Well, I think I would say something very briefly connecting the two questions and then pass the ball. The colonial wound can only be healed by the wounded. There is no other way to do it. So the question is, how decolonial healing works? To be quickly, psychoanalysis talk about psychoanalytic cure. And the psychoanalytic cure is to integrate a person to the society that disturbed that person. And that's not bad. That shall be done. But the colonial wound is that same society that through racism and sexism and nationalism and linguistics and knowledge has destituted a lot of people. And people who have been destituted are wounded. And that wound, the colonial wound, is not just physical. Could be physical, is physical, but has been destituted their own knowledge, destituted from their own normative grounding. And I think that this is a question, an open question to inclusion, because indigenous people in Canada, some want to be included, and others say, well, no, thank you, but no, I don't want to be included. Who are you to include me? So that is the process of kind of organization, a kind of the decolonial healing is always a kind of building the communal. You would use the collective, I use the communal, but I think we're talking about the same thing. So that is, that's my answer to the colonial wound. And connecting briefly to the other speaker, I cannot remember exactly the name, Madhukar. I think the list from the colonial medicine to global health, you see coloniality there. I mean, it's a kind of the transformation of the same kind of, as you show, it's a kind of same kind of policy, implicit policy. But from our perspective, this is very, very, very helpful. But the question is that the history of the colonial medicine to the colonial health cannot be just analyzed without relation to governance, without the relation to humanity, without the relation to economy, and relation to humanity, and without relation to control knowledge. I think that the graphic, where are the headquarters? Surprise, surprise, and you said it very clearly. We control knowledge, and I think that decolonization of knowledge here means to be precisely aware of this. And then I close with your question. What do we do? I think that the question here is, what is the politic, for me, of decolonial investigation in every field, health, economy, art, philosophy, etc., etc. So what kind of knowledge do we want? in our research and what for. So that is the answer you, dialogue.
So that's lots there, and that's lots to unpack. I want to talk for a moment about colonial wounds and historical trauma. And I agree. I think it's healing from within. Someone has to be willing to go on that journey to heal from that trauma. And what we teach in our communities as the first step is to know where that trauma comes from and the history of that. Because as I talked about, beyond the asterisk, being invisible, not learning things in the classroom, but truly learning them in traditional ways in the home, with family, with history, with oral histories and stories, with knowing where we come from. Those journeys of where we've been and the way colonialism has shaped, impacted, hurt, damaged, decimated many of our cultures, knowing what the outcomes of those and the impact of that has been is a process towards healing from historical trauma. And you don't heal from it forever. We call it blood memory. It stays in your blood. You pass it on. Just have to figure out how to acknowledge it, how to know where it comes from, ceremony, working through it, and to move forward. But that has to start from within, and it's with community. We're only as strong as the next one of us. And so right now in many of our communities, we're focused on the health of the whole community. And it's not just the physical health, it's the stress, it's the mental health, all of those that have physical ramifications for our people, because that does impact how we move forward in society. You know, I think you heard me say I'm an enrolled citizen of the Lumbee Tribe of North Carolina. That requires that I have citizenship. I mean, I am a citizen of that tribe. And in order to maintain my citizenship and pass it down, I have to maintain my lineage, my connections with my communities. If I don't maintain that over time, or it's diluted over time, then I'm no longer a citizen. I'm only a descendant. And there's so much here as it touches onto global health, finances, linkages to systems and connections. As we approach the U.S. Census, we're thinking about sizes of tribes and nations. Those are connected to resource allocations, primarily health, Indian Health Service resources and allocations. So this is also related. So I'm so glad that you talked about all the different systems and ways in which we can have colonial wounds, but also the healing, because it is health, but it's not just health. As you talked about, it's finances, right, where money and power and systems and structures come from as well.
Okay, Dr. Pai. Oh, yes, please.
Anyone else have a question? Come on down. Hi, my name is Laura Henneke. Among other things, I'm faculty at UNC, the School of Public Health. Thank you, and thanks to the organizers. I mean, this is just, my mind, probably most of you, it's like going in a million directions, and I have many questions, and just thanks for the data-filled presentations. I have many notes to take. I was really curious. I know you, Maiju, asked or said something like, for others to lean in, some of us might have to lean out, and I'm very conscious that this is a room with a lot of students, some of whom are from high-income countries, who are thinking about their future in global health and very excited about it. And the number one question I get a lot from the students I work with is, I want to go work in global health. How do I get started? Where do I go? Are we telling them to lean out? It's a little scary. And I think about when I started this, a few decades ago, there seemed to be opportunities to, go somewhere for 3 weeks, go to Peace Corps, do it for 2 years. And so what are the opportunities, and how can students who are working on their public health degrees and global health degrees, what role can they do this, and how can they do it in a way that's very respectful of the need for diversity and inclusion and the need to decolonize global health? Thanks.
What a beautiful question, and I'm so happy that half an hour ago, Shay and I had the exact same discussion in the corridor, almost mentally preparing for this. So my biggest anxiety about these discussions and these meetings is that will we kill and disillusion the spirit of these young people here, everywhere in McGill, all over the world, who genuinely want to do good things, right? And that's exactly what you were asking, and I can see it. And I am funding a whole bunch of them to go do global health. So am I doing something bad? And if we kill their spirit, and I think they're looking for a mission in life, a purpose in life. I mean, why are they getting inspired by Paul Farmer or whoever? It's because purpose is important, and young people today really are much more into social justice than I think any other generation. So I hear you, and we don't want to kill that spirit. At the same time, we have to be thoughtful about how we do and structure and work, be respectful and make sure that they do it with humility. And so this is an ongoing anxiety. I don't think I have a clear answer. But what Shay and I did discuss half an hour ago is, could we also encourage them to address inequities locally? If global is local or if local is global, maybe that is a way to tell them, you don't have to fly to a remote workplace in Uganda to do anything good. Do them here in parts of Durham or in underserved areas, because there's a million problems to solve, and we need to also worry about that. And that immediately anchors them. But the problem here then would become, the global health professors like us, me for example, will also need to work locally. Right now we are flying and jet setting around the planet, and we think that that's global health, right? So if Paul Farmer is in Haiti or Rwanda, then who is the equivalent Paul Farmer who shows them where to go and work locally? And how do we foster that culture? So suddenly we need to broaden the discourse to make global and work indigenously. So in my university, I happily fund students who want to go and do work in the indigenous communities among the refugee population. So we are very happy and widening it. We're not saying global health is only about LMIC. I think that's important. And then the last reason, I think, to invest in a young person for that first trip or experience that they have, whichever part of the world they go, it doesn't matter, is that they come back changed and transformed, and they understand their privilege. To me, even if they do nothing in future on global health, that first experience often is a great way for them to think as global citizens. At the minimum, that's what we want. Everybody thinks they're part of the globe and they're global citizens, and they feel the pain of what it means to be on the other side, and they easily know that if they had been born there, their life would have looked very different. Right? At a minimum, if they come back and say we are all global citizens, then at least the world is better for it. And I think to that extent, I'm still happy to support these field visits and whatnot. It's a tiny $2,000 plane ticket, but it could transform that person and make them a global citizen. And who knows, one day they may do great things. So I'm quite okay with that.
So the question is, in terms of the interplay between global health and the global economy. So we all know that the planetary economy is mostly capitalistic, not really based on principles of equity or equality. It's more profit loss. You have trading blocks, you have copyright protection. Most of the patents are owned by high-income countries. So if that's where the money is, then even with our best intentions, all of the grants and all the funds will be in HICs. So how do you navigate sort of that environment?
That was exactly my last slide. I am not convinced global health will change unless the underlying serious economic inequities of this world is addressed. Because, I mean, if 12 people or whatever, 12 white men have as much wealth as half of the world's population, what is that saying to us? And how do we fundamentally change anything with that level of dramatic inequities globally and even within countries? Right? I mean, it's just bonkers. And so I'm so happy that we are starting to critique things like Davos now, right? Because earlier we thought that was the best place on the planet. And now people are saying, what is this meeting? And who is there? And what does it say about what? It's like people are critiquing the whole enterprise of how this is being done. And please read Anand's book. It is one of the most gut-wrenching and important pieces of work I've ever read. And if you don't want to read it, watch Hassan Minhaj's Patriot Act. One episode, funny as hell, but hits you in the gut. So just last week, I finished watching 5 seasons of Gotham, binge-watched it. And Gotham is a beautiful example of inequities, right? Not a single billionaire, including Bruce Wayne, structurally does anything, including the Wayne Corporation, which is like the evil empire. They do nothing as that, and he goes at night beating up the bad guys wearing a cape. And he likens billionaires to be exactly that. They create all these problems, make ridiculous amounts of wealth, and then they give away a tiny bit as philanthropy, and everybody gives them an accolade and an award. And he's saying if they paid their fair share of taxes, then you don't need any philanthropy, you don't need Batman at all. How do we get rid of Batmans of the world is what we should all be asking. And that means democratic processes, going out and voting, selecting candidates who believe in this. And there are candidates in this country who are exactly talking about wealth tax, who are asking all the right questions about universal health coverage. Why are we not voting them into power? Because that's how we'll fundamentally change these inequities, and that will reflect in global health one day. But right now, just changing global health when the underlying structures are exactly what you said, it boggles my mind, and I cannot imagine how to do it easily. Because the whole thing is designed to make the rich people richer right now, and that includes privileged people like us.
2 points. Where the person who asked the question? Oh, over there. One general related to the previous conversation. I think what I will say, I am saying to my student, not in global health, but in kind of coloniality, decoloniality, whatever, is in this case, I will say global health is irrelevant to heal the colonial wounds, which doesn't mean that it's relevant in other fields. But I think that students should be aware of that global health is not the kind of Western solution for the rest of the world. And the rest of the world is much larger than the North Atlantic. So that is kind of that humbleness, the possibility of listening to other cosmology and not to think, to take for granted that Western cosmology that has been erased in the 18th, well, it's a complex question, but has to listen from other cosmology. Because in the case, let's take this example, in the case of exclusion, which I get destitution, doesn't matter how we call it, it's a different kind of discourse in which, if you want to include, let's say, a Native American, which is good, but is, at the same time is problematic. Why? Because you ask that person to kind of relinquish his or her normative grounding and to be integrated to the normative grounding of the West. So that inclusion is good, but at the same time is problematic, and I think we have to be aware of that. How do we preserve or allow the student or the person to preserve his or her normative grounding and not to expect that he or she should, which was coloniality all the time. So the question for you is, I was thinking about that while you were talking, is we have to be humble ourselves. Because what are our possibilities with the kind of the pharmaceutic and the hospitals and the insurance company, etc.? So what kind of research we do and what for, as I said before. And I think we have to be aware, number one, that the healing probably has to start from us. We who are talking about public health, but are involved and kind of embedded in that kind of civilization that is talking about global health. And if we kind of move into dealing with other cosmologies, again, we have to be kind of aware of that. For example, I give you an example and then I pass the microphone. Many years ago, when white feminists from the United States went to the south of Mexico to tell the indigenous woman to liberate themselves. So the indigenous woman said, what do you mean by liberating themselves? So they're trying to explain about patriarchy and all this racism and all that. And I say, oh, that's what you mean. Well, with our men, we have problem, but we deal a different way. Number one, because we know how to deal with them. And number two, because they are racialized and they are inferior to the white woman from the north. So that kind of question, the kind of the humbling of our kind of position and the possibility of listening can contribute to heal the colonial wound. And the last point is that the concept of health is basic on the basic assumption of Western cosmology in science, because science has a cosmological basis. We are not going into that, but it's kind of the materiality. It's like health is the materiality of the body. And when we talk about the colonial wound, we are talking about a complexity of things. So talking about that, I think that we have to kind of be aware of our own limitation when we talk about global health in relation about the struggle of other people to heal the colonial wound. So I think that those two things coexist and will coexist for a while, and we have to be aware and how to deal with that after, what kind of research we do, and what for, and how do we deal with this kind of situation.
So we have 3 questions. We'll take them all at once. Maya, you want to start?
So for starters, I would like to thank the organizers. I really admire you all for doing this. As a recent graduate with my Master of Science in Global Health from this institution and a new professional, it's something that I really do think about how to decolonize global health, and I have taken the local is global approach currently. So my question for the panelists are, how do you suggest institutions and just organizations in general foster the type of experience Dr. Pai suggested, more instead of a more colonialism approach? Because I think your approach to what you said, it seems very reasonable and it seems as if it is ideal. But how do you think, like, what are some actionable steps you guys think that institutions and organizations can take for students and new professionals?
Thanks, Maya. Next question. We're going to take all 3 at once.
Hello. Yeah, you have to speak very close to this mic. You know, you almost have to lick it, I guess. But I'm actually an MD MPH, and I saw my first AIDS case in 1978. That was 3 years before it was described. And I'm writing a book out of Africa, out of New York, how AIDS spread around the world. And if you look at the AIDS epidemic, we think of it as something that's coming from there, right? But in point of fact, the very first case of AIDS in South Africa came from the United States. And that's been very well documented. And there was a second epidemic that happened later. If you look at the tuberculosis, in other words, there's a synergy between AIDS and tuberculosis. If you look at the tuberculosis in South Africa, it's all Western lineages, right? I mean, if you look at the East Cape of South Africa. So how do we, the United States spends 45% of what the world spends on healthcare. And everybody agrees that there's $1 trillion wasted. And yet the West is somehow spreading the disease because that's where, the people travel from Europe. How do we become aware of that in the equation of colonialization or whatever?
Thank you. Last question.
Hi, my name is Julie Welch. I work for a local nonprofit public health organization called FHI 360. And this is more of a comment than a question. I'm someone who works in the weeds. I manage clinical trials research in developing countries. And we just finished a very large trial of almost 8,000 women in Eastern and Southern Africa that was funded by Gates, published in Lancet, conducted in mostly South Africa. But we worked really hard and I think successfully to shift the center of gravity to the focus being on in those African countries. There was 4 countries. And I guess my only comment is it's really complex. It takes so much energy to shift that center of gravity, involving research ethics with local IRB boards, not just U.S. Having the community advisory boards is so essential to get into the community and get input from participants, following good participatory practice and how we do it, as well as like the drive of the science. I mean, the drive is this is an important question we were looking at, and it shifted policy. WHO was involved, and yet, so the idea was we want to get this into the most prestigious and well-read journals. We presented it, though, in South Africa, I'm very proud to say, is where we did the results presentation. So I guess my comment is it's complicated and it takes so much energy to do this.
Thanks. So there's some thread through all those 3 questions, and we'll just go down the line and hear final comments from Mignolo, Amy, Madhu, and Maleki. We also want to hear from you. Please.
Yeah, thank you.
Okay, we'll start with you, Maleki. Go ahead.
Okay, thanks. I think the questions are quite good and insightful, which lead us to a deeper reflection. I respond particularly to the question of what do we do as institutions, whether we are looking at research institutions or policy institutions, implementation institutions. Really, the starting point is to acknowledge the existence of this problem. We have to come to the reality and really acknowledge sincerely that there's a problem in the way we've approached the global health problem or global health policy and research. It's more or less what Amy was really talking about. It's one thing for the problem to exist, it's one thing to talk about it, but it's one thing to really internalize. The second is to think of some practical steps. I think the working group that has organized this conference are some of the practical steps. Just think of if time would have allowed, would have had the experts. This would be national and subnational health directors, planners, community workers from the global south who will share with us some of the experiences. As I've pointed out, they have very rich experience. They have great insights. They have not published the way a couple of us in this panel have done. But when you talk to them, when you listen to them, you sense that they do it. So this is one of the things that I feel Duke University could do. Can we invest in this? Can we get these voices? Not just to gather the information, but actively engage and involve them. What about holding the next conference and panel in Rwanda, in Nepal? It will really, and then it will be like the way the students have organized. You will collaborate with your friends and they lead the way. So if you could get mechanisms of where the global south and the many voices that have been neglected can actually lead the way and open up the spaces on journals, in research, etc., etc. So I think acknowledging the existence of a problem is crucial, but taking some practical steps, even if they're modest, will get us moving. And I was glad to be invited to this panel to share some of these insights on, how do we use tacit knowledge as a tool to help us challenge and contribute to reversing the existing narrative in global health.
Thank you, Maleki. Thank you. So just quick wrap up, each of you, and then we'll break. Thank you.
Okay, so I have 3 points. The first question is about institutions, the second about spread virus, and the third I will take the question of ethics. So the general question is, whoever control money, control meaning, and that is related to your question. If you remember when I put the enunciation has 3 components: institutions, whatever, actors who run the institution, and language. So the 6 now is the kind of the 3 modern imperial European languages, and English especially, are kind of running the show, are controlling money and are controlling meaning. So the question is that our struggle for decolonizing knowledge, because as I said before, the question is to not decolonize health, but to decolonize the kind of assumption and the conceptualization we have today about health. So our kind of decolonial activity there is the confrontation with the control of money and the control of meaning. The possibility of kind of having an impact in the institution that kind of run public policy, I don't know. I just leave to people who are working on that on that area. But the question of knowledge is fundamental, because if we don't kind of shift our geography of reasoning, we will just try to change the content, but not the term of the conversation. And for me, the question is to change the term of the conversation. And in this case, is how do we think not just about the physical health, but about colonial wounds and how wounded people fighting to heal themselves. And that is related to the question of ethics. And I think we cannot forget that in the cosmology of the West, global health is related to development and progress. And development progress means, well, living better. But if you go to indigenous cosmology, they are not trying to live better, they are trying to live well. And if you take, for example, one example of Nahuatl cosmology, their preoccupation was to keep equilibrium and balance in a slippery world. They don't care about development. And if you go today, the indigenous people in the West, they don't care about development. What they are trying to restitute, and that is a kind of epistemological reconstitution, to reconstitute their knowledge in order to live well. Kind of summa causae is a term in the South. So that is a question of ethics. To understand that there is goals of life, goals of living in other cosmology that are not ours, and we do not pretend that the progress of universal history places us as Hegel in the present of time and in the center of the world. So that is the question of ethics. And the question of virus, I think, is very important, and it's related, and I like the way you kind of connected the spread of virus and money. So I think that these are issues that we can contribute in our kind of research. When I said what is research for, in my perspective, the colonial research is to confront the coloniality of knowledge that create this kind of situation.
Thank you. Final thoughts.
Final thoughts quickly. I want to talk for just a moment at the time on institutions, as it was raised. I can't go back and earn this alphabet soup in the way that my ancestors were taught here on this land. We were taught on the outdoors. Degrees didn't matter. It's the knowledge and living well that mattered. We don't live in that society today. That knowledge has value in my community, a different sort of value than the knowledge gained from engaging in these sorts of academies. So we can't just set aside whole institutions and yet still be able to engage and access systems that produce equality in this country, equality even in a colonialized sense, right? So we have to figure out how do we navigate the systems that we have, how do we decolonize those systems, that's what we're talking about, and how do we create space for others to engage and connect so that they can thrive as well. It's thriving. We're not going to change all the systems of power in any short period of lifetime. However, we all have the opportunity and power to change those spaces and places that we navigate, to invite other communities into the research development into the question development, right? Asking the questions that matter in those communities, inviting them to shape the structure of the study, going to them versus always bringing them to you. Those things matter, and I would say, you know, and even the language that we use, right? So the findings that we have, they are not innovative findings if they come from indigenous perspectives or other perspectives that have been tried and true for centuries, right? So it's even the language that we use. So this work is really hard. If it were easy, it would already be done, right? We would shift some systems of power quickly, right? But it takes all of our efforts in order to do that. So do it in the spaces that you can. Push, try when you feel like you could have done better, we didn't quite get that right, try something else, keep at it, because it's not human nature. Equality doesn't seem to be human nature. We haven't figured that out yet. So we have to keep working, every generation, every person, to navigate and to create the equality and inclusion that we're seeking in health and in other spaces as well.
Thank you. Two practical suggestions. In 2020, we'll all be outraged and upset if this was an all-male panel, right? Same thing needs to happen. Every global health panel must not be just a bunch of high-income country people talking about global health. It is just unconscionable. We need to call it out and say this is not meaningful, because you are not closest to the problem. You will never be closest to the solution. Bring to the table those who can speak from the heart and speak the truth. That's one. Number two, for every student we send to a low and middle income country, can we at least receive one student? Can we be reciprocal in our relationship? And this is not going to be easy, I guarantee you. Your own government will not give them a visa. You will have to fight tooth and nail to bring them here. You will have to dig deep into your cash pockets to pay for them to come here. But you must allocate some of your resources to be reciprocal, and you got to fight it out all the way to make it happen. Maybe it will not be one-to-one to start with. But for every 5 students we send, can we receive 1 to begin with? I think these are 2 suggestions. And lastly, I am now on a whole bunch of publications where my student might be the first author, but I am not the corresponding author. My collaborator in India is the corresponding author. I have given up that spot intentionally, deliberately, and it's a much happier relationship than it used to be in the past. I'm no longer craving, but I also acknowledge that I am now a tenured full professor. So I am able to lean out way more than I would have done 10 years ago when I was an assistant professor. But at least the established people among us must and can afford to lean out. We can. It is not impossible. We can give up our spot on editorial boards. We can give up our spot on the keynote and get the right person to speak, more knowledgeable people than us. We can totally do this because it's not going to hurt us. But if we're not doing it, that means we have not woken up. Thank you.
Thank you.